Good afternoon, everyone. Thanks for joining. My name is John Lee, and I work at United Health Group, or I work at Optum, a United Health Group company. My background is in epidemiology, and here in Optum, I lead a group of data scientists and clinicians, statisticians, and analysts that work on methods and models that go into our analytic products. The company creates for payers and providers. The products generally are used for cost prediction, risk adjustment, care management, and inside the products are various predictive models as well as clinical measures that assess gaps in care and clinical conditions. So today we're going to talk about something that's pretty important to us and then in the world in general right now. And it's incredibly complex and still evolving, the topic of COVID-19 and health equity. So my primary aim is to encourage others to think about and pursue topics of fairness and equity in their own work. I believe we should all be having open discussions about this as we approach these types of questions. And it's not easy or clear, or there's not even best practices at this point to some of these challenges. And we're kind of figuring out things as we go. So really enjoy the opportunity to talk to a more diverse group of people. So beyond that, the topics here are fascinating and I hope engaging to this group. I'll try to highlight some of the open source programs we use to help answer some of our questions around fairness. So in general, we all come at these issues from a lot of viewpoints from different social locations and with different lived experiences, which is why I like presenting the settings like this, which include people from outside the traditional healthcare industry. So normally I like doing this presentation in a more interactive discussion format. I know this venue doesn't um, totally lend itself to that, but it looks like it's a pretty small group today. So feel free to ask questions in the Q&A or chat as we go, and I'll try to address them. There'll also be time at the end for questions and more of a discussion if people want to hold questions to the end. So let me try to advance my slide. Okay, here we go. So this work that we're going to talk about today was designed for Optum Performance Analytics, which is a provider-focused product that normalizes and enriches clinical and claims data for analytic use. This slide is a bit dated. If you take a look at the snapshot on the bottom, you'll see that it's only 18 million confirmed COVID cases worldwide, which is much, much lower than we know reality is today. And then the date stamp is August 5th, 2020. So I wanted to keep this in here because this was a snapshot of what was going on when we started this work. So at this time, there's a real urgency around this topic to support intelligent response to an increasing threat of COVID. So there's a real need to do something. So OPA clients had requested COVID-specific predictive models that leverage the rich data they provide to the platform. And we just recently reached a threshold of data across the cohort that allows for meaningful COVID analytics. So the need to find patients at the highest risk of severe outcomes for direct support and protection, and a need to understand risk for determining the right care setting and timing for non-COVID care. So let me go into that a little bit more because that might have been a little unclear. So at the time, our clients really had two ideas in mind on how they wanted to use something like this. One was to identify patients for intervention that might have been at high risk for a severe case of COVID. So more care or some other any clinical intervention they could do. And the other part was redirection. So at the time, I think people probably realize there's a lot of telemedicine being ramped up. So they're trying to figure out who would be better in a telemedicine setting, so not coming into the office and being exposed. So that was the time frame we're working on this in. And I did want to just take a step back to show, or maybe take a step to the present to show what it looks like now. So I think a lot of us, when we're working on this in the summer of 2020, we didn't expect the world to be the way it is right now. So COVID is still very much a problem around the world and in the US. So a lot of the things we talk about today are still pertinent. So in the context of rising cases and increasing ICU, that wasn't the worst of it. So fairly early on in the pandemic, the New York Times published this information based on data from the CDC showing large disparities in COVID cases. The focus here is on race and ethnicity, but I just want to note that those are not the only groups impacted by health inequities and many other kinds of bias and oppression. Women, disabled populations, LGBTQ community, to name a few. Even within race and ethnicity, there are other important subgroups. Though not in these graphs, the article does describe similar disproportionate impacts on Native American populations, for example. Infection rates were more than double and triple comparing whites to blacks and Latinos. And if you look at the age-specific breakdowns, they get much worse in certain age bands. So as many think, best way to measure a country's success as a society is to measure the degree to which the society cares for its most vulnerable populations. Now, you might not ascribe to that as a sole measure of a country's success, but I'd argue it should be somewhere on the report card. And what you're looking at here is not a good grade. It's an F. It's no secret to most of us that there have been persistent and glaring differences in care across subgroups in the US. This is also not a new phenomenon that occurred due to COVID, but COVID has starkly exposed the issue, in part because the data was available. It's really a sad situation that was going on. And it's important that we're careful in how we interpret that story and how we tell our own stories with analysis that we might do. So a little more background. I'm by no means an expert on issues of disparities and health inequity, but it's something that we are focusing more and more on. I'm not going to spend a lot of time on this slide, but it's an attempt to describe some underlying principles that I've found helpful as we think about the intent interpretation of analytics oriented around race and ethnicity. Really important to be aware of and keep in mind that race and ethnicity are not biological truths, and we want to be clear about when we talk about data that includes race and ethnicity that we don't inadvertently reinforce a biological interpretation. Clearest thing to do is to make that point clear and to explain what is going on in a specific situation, to describe the societal mechanisms that create the disparities. What not to do, ignore the issue. Avoiding including race and ethnicity in your work. We have to see where disparities exist and exist to have any hope of repairing the issue and in not amplifying the negative impacts. So how does this relate to COVID-19? So the main question that we were thinking of is, am I going to die of COVID-19? So that can be broken down into risk of death. Let's take a step back. Here's one way to break down COVID-19 risks. These two broad areas can have been separated by various organizations and in various models. Organizations like IHME provide geographic risk of infection and high-level forecasts of death. The CDC, on the other hand, has focused their efforts on the question on the right: what patients are at high risk of severe outcomes. OPA predictive team is focused squarely on the same question through the lens of inpatient admission. What we eventually realized is that we needed to clarify and categorize the different risk factors that impact infection risk from risk of death, because there are some important differences, especially when it comes to the impact of race and ethnicity. Some of the key risk factors are quite different between these two. For infection rates, you can imagine starting with geographic risk, existing and forecasted rates in local areas, and the restrictions in place to slow the spread of disease. But beyond that, individual exposure varies widely from one person to the next for a host of factors. I very intentionally try to be more explicit here than just saying social determinants of health. The examples are more meaningful to me. Network effects. Now think about not just your own risks along these lines, but the risks faced by those close to you, your family, friends, colleagues, neighbors, and community, and then your exposure to them, and by extension to their exposure. We're all carrying collective risks in this way in some kind of network effect. Flip to the other side of this, and biology and underlying health play a huge role. Your age, comorbidities from obesity to heart disease, strength of your immune defense, nutrition, etc. And beyond biology, the quality of care you receive. So again, these are different risk profiles. Now, if I think about this personally, looking at all these risk factors on both sides, imagine highlighting those that I face an outsized risk for, and imagining those where I don't have any risks. I feel like I'm pretty privileged. I work in a job that can be done remotely, and I can even attend and give presentations remotely. I have access to healthcare, and I know how to tap into resources. And even then, I am still fearful for myself and my loved ones. The story couldn't be more different for some people, having no choice to go into risky work environments, taking public transportation, get there and home, and carry those risks to home that include multiple generations or multiple families, and to know that every around me was carrying, circulating that same level of risk. Across the community, these cease to be linear risks. They compound and they compound within communities that carry higher prevalence of the condition that leads to death. Like I said, sitting here safely talking to you virtually, I can't really imagine what that would be like. Maybe some of you can, and I hope we have the opportunities to hear and learn more from you too. So let's turn to the project. Oh, on this slide, I did want to take a step back and highlight this slide now. So on the previous slide, we did not include anything about vaccinations because they didn't exist when we built this model. So of course, vaccinations still have equity components, and it does change the equation on how we look at this. But at the time of this work, it wasn't something uh, that we had factored in. So back to the model we initially developed, and this is an approach we have attempted to take amidst all of that. This team had already been doing work, some work related to health equity, but this represents a much more direct and proactive effort than we've undertaken in the past. It's still very much unfolding. This is only a fraction of the work done so far and the work we're continuing to pursue. So walking through this slide a bit, the goal of this project was to create a predictive model to predict severity of disease. And with all the context we discussed earlier, we are very cognizant of trying to not amplify health inequities, and we're looking for methods to measure that as best as we could do. So we went to look at open source tools that were available to diagnose bias in models, and then later on in this presentation, we will talk about the Equitas model that we had chosen to use here. And this isn't suggesting that this is a cookie cutter approach or it's a necessarily the best practice. It's one we decided to use. It's an attempt and hopefully useful as an example, and also useful to normalize this kind of work and to encourage others to engage in similar efforts. Before we get into what we've learned so far about fairness aspect of this, let's start with the context of the model and some traditional performance metrics. So going a little bit more into the model and the parameters and what we were thinking about when we started this. So the client base is really health systems. So this is provider side in hospitals and ambulatory care settings. The primary use case was to prioritize patients with high risk and severe outcomes. So that's for outreach and support, and also for direction to particular sites of care, meaning mainly telemedicine or in person. So the underlying data was EMR data from the providers, and the modeling data included 21,000 COVID patients between March and May 31st, and we use a 12-month look back period on to assess their comorbidities and for past utilization. So this focused on adult patients, and it crossed different payer types since it was on the provider level. So the outcome predicted was inpatient hospitalization within 30 days. And in this cohort, the admission rate was about 20%, so much higher than average population. Modeling approach was ridge regression and used about 2,800 markers that were fed into the model. I think the final model had about 83 left. So in here, the data we had did include race data, and it was populated for about 88% of the total population. And as a proxy, so if you remember back earlier, we talked about, or earlier in the slide, we talked about the severe outcomes. So severe outcomes can be defined in many different ways, but then for us in this model, we defined it as actual inpatient admission. So the proxy of a severe outcome was an inpatient admission. So some people can argue that's not the best definition, but then it's the one that could be categorized the best. So in OPA, we typically have the ability to create multiple models based on the types of data that the clients might capture for specific patients. Clinical data only, claims data only, combined claims and clinical data. In this case, we started with a clinical data only model, and part of it is also for the use case. So if you want to reach out to people who are already diagnosed with COVID, you really need to use clinical data because claims data is lagged. So by the time you know they had COVID, any kind of subsequent event or outcome would be long past. So you can see other important parameters and scoping here around things like look back period, the need to have information on patients. Decisions here are based on the expertise of the team around the data we're using. There's a lot more we like to do and test here, and that's going to be a theme throughout this presentation. Always more that could be done in these modeling efforts and alongside the urgency to help clients and patients. It's a fairly unique patient population. Inpatient rate is quite high. And one of the reasons for this is, especially in the beginning days of COVID, in the early period, a lot of the diagnosis was taking place in hospital EDs, so or emergency departments. So patients were already pretty advanced in their diagnosis. So as with a lot of things with COVID, this would evolve over time. Right now, the model would look different than it did when we built it. So here is the output of the model. So here's the model performance. We really focus on a few different things. Here are the results from the data. We run this performance against a holdout data set. As folks know, the key metrics to consider here depend greatly on the context of the model. We put a lot of focus on positive predictive value. So out of the people identified, how many did you get right? And then we also look at the IUC, which is the predictive ability of the model itself. So then here it shows two different cutoffs. So typically clients would use kind of a high-low cutoff to identify people. So then this shows at different cutoffs what the PPV would be. And a lot of times the cutoff to be used will be determined by the type of outreach and kind of the resources a client might have to do that outreach. Um, so this slide is a little bit crowded. There's a lot to talk about here, and I want to start by caveating everything here. So markers in this type of model need to be interpreted with extreme caution. Individual markers interact in complex ways, and some markers likely only carry weight for indirect reasons. So caution is very important. This type of modeling is not designed to identify novel and specific risk factors or protective factors of severe COVID outcomes. Don't rush out and start telling people to start taking serotonin. All that said, these markers should make some sense and can suggest interesting areas for additional interpretations and inquiry. Like if we look at this, a lot of things on here, such as the comorbidities and some of the other medications and age, all kind of align with what CDC was saying as high risk. So what do you not see here? Race and ethnicity, though included as potential markers, do not appear as independent markers. And just as much as we need some understanding of what does show up here, we also need an understanding of why race and ethnicity do not. So as a reminder, the two big areas of risk that we believe are elevated among racial ethnic minorities are biology or health and quality of care. So we do have a story. First, disease prevalence is captured in our data. There's no doubt that Blacks, Latinos, and other subgroups have higher rates of obesity, heart disease, diabetes, etc. What we believe is that we're already capturing that fact in this particular context. Differences in prevalence are largely baked in. Secondly, and more cautiously, we believe that the care impacts are being carried by indirect markers. Specifically, we believe that several of the protective factors are protecting patients with easier access to care, higher quality providers, etc. As one example, taking the flu vaccination, which is a protective factor. If you had a flu vaccine in our data, you're less likely to have an inpatient admission following COVID. Does that mean we discovered a cure for COVID? Not even close. Instead, what we hypothesize is that the flu vaccinated patients are more likely to be those with easier access to care, those more likely to have access to timely medical care when they become symptomatic. This is a much more tenuous story, so we would love to dig further into that depending on priorities. And there's also other published literature at the time showing similar findings that we found here. And what I can't stress enough is that these explanations are just theories. They provide no direct measure of the model's potential bias. But the cool thing is that we don't have to rely on stories. We have tools available to take a direct look. So here is where we get into the open source, some of the open source tools we used. One of the tools that I'm highlighting here is Equitas, which is what we used in this case. We have no involvement in its creation or distribution. It's a tool we found that seemed to fit a need we had. Important to note that Equitas is very focused on diagnosing bias, not as much on mitigation approaches. This tool seems great, relatively easy to implement and run, and can generate a lot of information quickly. The link to the tool on the slide is on the slide, and I would suggest people who are interested go there for more information. They can do a much better job at talking about the details of their tool than I can, but I'm going to talk about how we applied it. So the Equitas tool is really meant to be used on binary outcomes. So it works for our kind of logistic predictive model. And then often in the example that I was showing earlier, you would turn that kind of risk score into a binary yes, no. So that's what is really needed to for the Equitas tool. So IBM offers another set of free tools called AI Fairness 360 that the team has used in the past. That toolkit also includes diagnostics, but also has some approaches to mitigate bias. So this slide gets a little bit complicated. There is a lot on this slide, so I'm just going to make a few key points here. This is not dissimilar to conversations and decisions that data scientists make about right performance metrics for different types of models like AUC, PPV, and so on. Correct metric for performance, and there is no real correct metric for bias. So if you look at the brown squares across the bottom, those are different metrics that the Equitas tool suggests to look at, and you can't optimize every single one. You have to decide on what your use case is and which one is the best. You have to figure out that based on context and the type of decision you're trying to support. Just like modeling itself, this field is evolving and is a mix of art and science. Also, it should be thought of as collaborative with business users and clients. The interpretation is a learning curve, and we're still on that curve. Which metric matters, but what does each imply? And that is very different depending on the context of the model, its purpose, and its use. Last point, we thought it was important to select the metric we thought we most needed to worry about before we looked at the results. And you can see here that we picked a metric called false negative rate parity. To try to put that metric into words, we're really trying to ensure that we don't miss people in a biased manner. So the people we're finding, we find people equally. So what's some of the output? Here is some of the output from the Equitas tool. As you can see in the table below, for our selected metric, we found the model was balanced across the racial and ethnic groups, and we're able to compare. That was encouraging, of course, but there's so much more we can do. You can see a few of the other things listed here. So what we like to do is better understand and interpret these results across other metrics, diagnose potential bias introduced at levels specific to the clients, use the results to help inform the risk threshold buckets that clients should use. So now we've seen two things. First, that race and ethnicity did not show up as independent markers in our model. Second, that bias metrics suggest we are limiting bias for race and ethnicity. The next step at the time was to engage our stakeholders around the appropriate use of these models, considerations, and the considerations they had to make. Before we kind of go on to what we're working on now, I did want to go through this a little bit. It's a slide that's a slight divergence from the topic that we're talking about, but kind of worth diving into. As we think of our process, there are a lot of areas that introduce bias, and I'm going to go through them, go through a quick summary. So historical bias is data from the world as it was that leads to harmful outcomes. So example of that would be word embeddings in natural language processing that has bias to associate the words engineer with a male or nurse with female. Representation bias, the development sample underrepresents some part of the population. It fails to generalize well. That could be geographical. So data based on a Boston population can't be extrapolated to say Houston or Atlanta. Measurement bias, using a bias proxy for a measurement of interest. Examples medical applications diagnosed with conditions is often used as a proxy for condition X. However, systematic disparities can lead to higher rates of misdiagnosis or underdiagnosis in certain groups. Evaluation bias, the benchmark data used for a particular task does not represent the use population. So aggregate measures can hide subgroup performance. So example of this is worst performance for facial analysis algorithms or images of dark-skinned women, which comprise only a small fraction of the benchmark data set. So aggregation bias, a one-size-fits-all model is used for data in which there are underlying groups or cases that should be considered differently. Using one predictive model across very different cities when it would be best to have a city-specific model. And then lastly, deployment bias. So mismatch between the problem a model is intended to solve and the way in which it's actually used. So this often occurs when an AI system is built and evaluated as if it were fully autonomous, while in reality it operates in a societal system with human decision makers. So an example of that would be using a predictive model, let's say using a cost predictive model as a proxy for a health outcome. They're not predicting the same thing, so that would give biased answers. So all these different biases today, what we talked about in our model building and really our evaluation of fairness, only addresses some of it, only addresses parts of our problems. That's why we really try hard to engage stakeholders and clients in further discussion on how models are used, what the use cases are, to avoid some of the other items and be as equitable as possible. So what are we working on now? So where are we taking this? So we would, as a company, as work we do, we're prioritizing the use of demographic and SDOH data, moving beyond missing data as an excuse and prioritizing gaps as an obstacle to overcome. We are building kind of this measurement of fairness into everything we do. It's just part of the work we do now, but that's only a piece of it. So, prior to model development, prior to any kind of work we do, we try to think about the use cases a model might be used for and the potential disparities that are inherent in the questions we're asking, the people being identified that we need to think about. And then beyond that, working on mitigation efforts. So if the modeling testing does show things to be inequitable, what do we do with that? Like, what are the steps we can take to fix those things? The other part of what we're doing is sharing our experiences. So talking to other people in the industry, talking to other people in the company about what they're working on, how to ensure fairness. And then UHG as a broader organization has efforts ongoing to help increase diversity among our analytics community. So kind of lastly, the big takeaway we have for a lot of this is that this is not just a problem we can solve, that it really takes proper development of models, proper usage of models, and more people thinking about these things to really help ensure that we don't perpetuate kind of disparities that are occurring in the data being collected. So with that, that is the end of the formal presentation. My contact information is up here. Thank you very much for your time today and listening to this.